Hi, everyone. Welcome back to the Breast Cancer Podcast. Hello, I'm your host, Dr. Deepa Halaharvi, a fellowship trained breast surgeon, and also happen to be a breast cancer survivor, thriver, and a warrior, living my best life. As you know, breast cancer affects millions worldwide, touching lives in a profound ways. Whether you're someone facing a diagnosis or a supporter seeking information or just eager to learn more, this podcast aims to be a beacon of understanding, hope, and empowerment. I'm here to talk about all things breast cancer, from surgery to survivorship, as well as high risk for breast cancer to metastatic breast cancer. My goal is to provide you with reliable information, share inspiring narratives, and foster a supportive community. I know firsthand the challenges breast cancer diagnosis brings. Throughout this podcast, I will give you strategies to handle difficulties that arise from cancer diagnosis. We'll have insightful conversations with medical experts, researchers, survivors, caregivers, and advocates. I will tackle topics that impact our lives as cancer survivors. My goal is to educate you and empower you to live your best life. I definitely have. Well, let's get started. Hello, everyone. Welcome back to the Breast Cancer Podcast. Today, I have a special episode dedicated to Women's History Month. And my name is Dr. Deepa Halaharvi. I'm a breast cancer surgeon and a survivor and a host of the Breast Cancer Podcast. This topic is extremely exciting for me because it shows me where we started and where we came from. So, March is Women's History Month. So, I want to talk about the history of breast cancer from radical to defined, how breast cancer surgery evolved. All the pictures I used in this PowerPoint are from Google. So just Google pictures there. So credit to Google. So I don't want to be copyrighted for that. All right. So happy Women's History Month as we kick off this Women's History Month, looking at the breast cancer history. It's not just a medical retrospective. It's a story of how women fought for their bodily autonomy, changed the landscape of clinical research, and transformed a hushed diagnosis into this global movement. It is a heavy topic, but one that highlights how far we've come, not just in science, but in our willingness to speak openly about women's health. Breast cancer surgery used to be extremely disfiguring and disabling. Over time, studies proved smaller operations could work well for survival. Over time, studies showed that a lumpectomy with radiation is just as same as a mastectomy for survival. And I'll go through all of those studies with you in just a little bit. The evolution is about science, is about patient's voice, and also rethinking of what works for the patients without disfiguring them. So let's start with the pre-modern era. That is back in the ancient times. Edwin Smith Papyrus in 3000 BC, he described breast tumors as cool to touch and as something incurable. So if you got cancer, you're done. That's it. But then Hippocrates was the first person to use the word cancer and use the Greek term carcinos or carcinoma. Basically means it looks like crab. Then there is this theory in 2nd century, Galen, he believed that cancer was excess of black bile. Surgery was often avoided as it was thought to provoke the disease. And now we know it's far from truth. So the barber surgeon reality is where before the anesthesia, surgeries were performed just while patients were awake. They did not have anesthesia. Could feel every single thing. And as you can only imagine how brutal the surgery was for these patients. And these patients did not survive the surgery, forget about the cancer, because the surgery was so brutal. Then there came the era of mutilation. That was almost about practice for about 100 years. This is where the breast tumors were described as going in a centrifugal theory, meaning it starts in your breast and it spreads outward. And it's actually called the Halsted radical mastectomy. Prior to him, the visible lumps were removed, but without any systemic therapy, the tumors would come back. But William Halsted, in 1882, he came up with this surgery called the radical mastectomy. This is the belief that the cancer spreads outward, so outward spiral from the breast. So the procedure was called radical mastectomy. This involved removal of the breast, the pectoralis muscles, the chest wall muscles, the lymph nodes, all in one surgery. So, and the impact on women was very drastic. Yes, it did reduce local reoccurrence because they removed so much of the body, of the breast and the muscle and the lymph nodes. It left patients very disabled. They had lymphedema, they had hollow chests. And this halsted mastectomy, this morbid procedure was called was standard of gold standard at that time for nearly about 90 years. Just imagine women woke up without breasts, they woke up without chest muscle, they woke up with significant arm swelling, and they were told that this was necessary for survival. There were no randomized trials at that time. There was no long-term data. But this was very effective in keeping the tumors coming back, but it left women extremely disfigured. And, and this was a simple belief, and women did not question surgeons at that time, and they just took this as a gold standard. Then there was a huge paradigm shift in the 1970s, and this happened with Dr. Bernard Fisher. He challenged the theory of Dr. Halsted, and he was the pioneer for this NSABP 04 trial, National Surgical Adjuvant Breast and Bowel Project 04 trial. Basically, he argued that cancer is a systemic disease, not a disease that goes outward. And so what he said was, instead of performing such a huge morbid procedure, you can perform lesser surgery with the same survival. So he developed this from going from a radical mastectomy to modified radical, meaning now they're not removing the muscle, they were removing still the breast tissue and the level 1 and level 2 lymph nodes, and those are the lymph nodes outside of your muscle and underneath the muscle, but not the level 3 lymph nodes, which are inside of the pectoralis minor muscle. As you can imagine, this did not leave women as disfigured as the radical mastectomies. And also back in this day, women would go to surgery. They did not have the biopsy of a cancer. They would go to surgery as a one-step procedure where the surgeons removed the tumor. And if they found out that that was cancer, they would remove the breast. So women went to surgery without knowing whether they would wake up with or without breast. Just imagine that, going to surgery, not knowing whether you will have breast or not when you woke up. And this was challenged, and there's this advocate journalist, her name is Rose Kushner, and she like fought against this one-step procedure. And sometimes women will ask me, why don't you take me to surgery, remove this mass? But it's really important to know what type of cancer, what are the hormone receptors, so we can treat it appropriately, rather than putting women to sleep, removing the entire breast, and for women not knowing whether they're going to have breast or not when they woke up. So she was an advocate, Rose Kushner. I would say she was probably the most influential woman. There are so many women that are influential for the history of breast cancer, but I would consider her to be the most influential because she really fought against this one-step procedure where women went to sleep and woke up without breasts, which to me, that just feels very appalling. Speaking of other women, and I just wanted to mention a few of them, there's a number of them. I did not have time to include everyone, but there is Dr. Jane Cookwright, who was known as godmother of chemotherapy. She helped develop methotrexate. She was the only one woman among 7 founders of ASCO, American Society of Clinical Oncology. There is Mary Claire King in the 70s. She proved that breast cancer could be inherited, and she's responsible for identifying the BRCA1 gene on chromosome 17. Her work turned breast cancer from mystery into something we could predict and prevent through genomic testing. Then there is First Lady Betty Ford. She was First Lady in 1974. Just weeks after becoming the First Lady, she went public with her mastectomy. I have to say, it is so hard to overstate how shocking this was in 1974. her openness led to massive spike in screenings across the US. And I think this is why I think for me, as someone who does the work and helping women with breast cancer, it's important for me to come out and talk about my own story. Because when you talk about your story and it doesn't then become a taboo, it gives people permission to talk about their stories. And you never know how that permission can, evolve and create, better outcomes and guidelines for other people, because now you're not, putting it in a box and not talking about it, you're actually talking about it. So the first study is the NSABP04. So this is where National Surgical Adjuvant Breast and Bowel Project, it performed in the early 70s. It questioned whether you really need radical mastectomy. That was Dr. Fisher. And it went, radical mastectomy versus total mastectomy. So there was a randomized control study. That is the gold standard study. That is where women subjected themselves into one of the two arms. And one group underwent a radical mastectomy. The other group underwent a total mastectomy. And they were follow-up results of this study to show there is no survival benefit in between these two surgeries, radical mastectomy versus mastectomy, when they did not have a clinically node positive disease, meaning one was node negative disease, one was node positive disease. It did not show any difference in survival. So what the conclusion from this study was, routine lymph node dissection is not needed in node negative disease. And this is important because thousands of women subjected themselves into these trials. So women like myself can go on and have lesser surgery, but then have same survival. Let's go to NSABP 06. This is again in the late 70s to early 80s. The question was, is the modified radical mastectomy, which is removing the breast, the muscle, removing the breast, not the muscle was the radical mastectomy, removing the breast and the lymph nodes, is that the same as breast conservation, which is lumpectomy with radiation? Also, another randomized control study, lots of women were, involved in these studies to show that the results of these studies, we have a lot of years, several years follow-up data to show no survival, meaning women who has a lumpectomy with radiation has same survival as a modified radical mastectomy, which is removal of the breast tissue and the lymph nodes level 1 and level 2. So again, lesser surgery is same survival, lesser morbidity for women. Going into the 80s now, into early 2000s, this is where, again, the lumpectomy became famous. There's multiple trials. There's Milan study. Basically, they were all looking to see, do we really have to do a lymph node dissection? Could we just do a sentinel lymph node biopsy? There was another study that was looking at that. What is a sentinel lymph node biopsy? That is looking at the lymph nodes underneath the arm. And a sentinel lymph node is basically, it is a first draining lymph node, and that's a gatekeeper of the lymph nodes. Is it enough just to remove the sentinel lymph nodes as opposed to doing a lymph node dissection? And that's what we were looking at in the 90s, I would say, is when that came about, when people stopped doing a lymph node dissection. Some of the other developments are oncoplastic surgery, where we work with plastic surgeon to remove not just the breast, and just like doing reduction, and then the plastic surgeons mobilize the tissue to create aesthetically pleasing breast, whether it's doing oncoplastic reduction technique or doing mastectomies with reconstruction. So for women on clothing, at least, nobody could tell that they had a mastectomy. There's different variations of mastectomies. There's nipple sparing mastectomy. I describe breast as a pillow and a pillowcase. Your breast is your breast tissue is your pillow, and the pillowcase is the skin. So nipple sparing mastectomy is where we preserve the skin as well as the nipple, but the breast tissue is removed. And the plastic surgeon puts either a temporary implant or their own body tissue to fill up that space. Skin sparing mastectomy is where we remove the breast tissue and the nipple, but then the plastic surgeon comes behind us to do the reconstruction, whichever option works the best for the patient. Then the Goldilocks mastectomy is pretty new in the last few years, and I have to give a shout out to Dr. Richardson, and she pioneered this procedure I believe in 2012. where the breast tissue is removed, but the skin and the nipple can be preserved depending on the location of the tumor to create a breast mound. These patients don't need reconstruction right away. If they don't want to, they don't even have to have reconstruction because they have so much skin that could look like breast on clothing. And you actually look like your breast reduction. And I perform a lot of these surgeries with my partner. And this surgery can be desired as a bridge, meaning if they don't want reconstruction right away, if they want to think about it, have it later on, that is fine. Or they could just stay with this type of procedure because when they look down, it looks like they have a smaller, reduced breast or, what looks like a breast reduction. Then there's total mastectomy with flat closure, where women opt to remove their breast tissue and have flat closure, which is removing those dog ears and things like that. So there's a number of different options for women these days. I alluded to this before, lymph nodal surgery versus axillary lymph node dissection versus sentinel nodes. As you can see here, the sentinel nodes are the first draining lymph nodes, and we inject the blue dye and the radioactive tracer. It goes into those first draining lymph nodes. We remove anywhere from 1 to 3 lymph nodes, as opposed to removing 10 to 20 lymph nodes with the lymph node dissection, which can decrease the risk of lymphedema. There are times when you have to do lymph node dissection, when there is cancer in the lymph nodes in spite of getting chemotherapy, where there are a lot of lymph nodes that we can't safely perform a sentinel lymph node biopsy. And I'll talk a little bit about that down the road here. So there is this another study called ACOSOC Z11. This is Dr. Giuliano is who gets the credit for this study, where he asked the question, what if women have 1 or 2 positive lymph nodes? Can we omit a lymph node dissection? For those women where you cannot feel the lymph nodes or do not feel the lymph nodes, or they may have 1 or 2 positive lymph nodes, they go to surgery with a sentinel lymph node biopsy. As long as they have less than 3 lymph nodes, they can go on to lymph node radiation without having lymph node dissection. Same survival for those women who get lymph node dissection versus no lymph node dissection. Because a lot of these women get radiation, they also get systemic therapy, whether it's chemotherapy and endocrine therapy or just endocrine therapy and radiation. No survival difference between a lymph node dissection, which includes removing 10 to 20 lymph nodes, to a sentinel lymph node biopsy, which is usually 1 to 3 lymph nodes. So again, lesser surgery, lesser morbidity, same survival. But guess what? Thousands of women took part again in these randomized control studies. Then there's this choosing wisely guidelines, basically for women who are over age 70, hormone receptor positive, small cancer, 2 centimeters or less. They don't need a sentinel lymph node biopsy. Studies have shown that there is no survival benefit for these women. Really, the better benefit is taking an anti-estrogen medication. But these women need to be committed to taking anti-estrogen medication if you're going to be omitting a sentinel lymph node biopsy. Most recently, there is this SOUND trial where we are actually extending that to women younger than age 70, where there is a small hormone receptor positive tumor, clinically node negative axilla, and you have to have an ultrasound of the lymph nodes to make sure they don't see any worrisome lymph nodes. There is no survival benefit in getting a lymph node biopsy versus not doing a lymph node biopsy. And this is usually in the postmenopausal women, and there is a lot of nuances. A lot of the hospital systems are not ready to take this on yet because there is a variation in how the axillary ultrasounds are performed across different hospital systems. But it is important, again, these women need to be taking an anti-estrogen medication, and they also need to get most likely radiation after surgery. And it really depends on this type of surgery they had, which is usually most of the time these women had lumpectomies, and the margin status and the type of tumor and so on and so forth. The hormone receptor status, usually they need to have hormone receptor positivity. So what did we find out through all these studies is aggressive surgery or the mutilation of what used to happen back in the day does not need to happen now. We have better understanding of the biology of the cancer. As a surgeon, I'm only doing a small part in removing the cancer. Really, the bigger part is done by the medical oncologist who gives you chemotherapy if you need it, the targeted therapies, the anti-estrogen medication, because we are now finding out is this disease is not just anatomical disease, it's a biology of the disease. We are also very interested and important for us to improve patients' quality of life, not just the way that they look, but also I'll talk about some other things that we look at, making sure we are addressing all the different components of their life. We no longer treat the tumor at the expense of the person. We treat the person by precisely targeting the tumor. And that is important. Again, as we are thinking about how we evolved in the back, before, the Egyptian era to now, the thinking at the time was simple. And even Halsted radical mastectomies, his thought process was the cancer spread outward. And so he removed everything on the chest, on the muscles, the lymph nodes, and it created a lot of morbidity. And he thought the more tissue you remove, the better chance for cure. Well, unfortunately, no one questioned him, right? So Dr. Fisher came around in the 70s and he questioned him and created these randomized control studies, which now resulted in lesser invasive surgeries, such as myself, who was diagnosed in 2016. And I did not need to have radical mastectomy. Had it was not for Dr. Fisher and all those women who sacrificed themselves in putting themselves in these trials, I would be getting a radical mastectomy. So women in the 1800s woke up without breast, without chest muscle, significant arm swelling, permanent disability. They were told this was normal for survival. Well, what's important to understand is this. At that time, there were no randomized control studies. And that is important is what we are recommending to you comes from randomized control studies, whether it's surgeries, whether it's systemic therapies. We have more data, survival data now. Back in the day, they didn't. And back in the day, women did not question the surgical authority. And now we do a better job of patient, it's shared decision making. It's what's, works the best for the patient for the situation. And which is, I think it's important. It's not paternalistic anymore. And the questions that researchers began asking is, what if we can remove less and achieve the same survival? And therefore, all those randomized control studies happened. We went from radical mastectomies to modified radical mastectomies to lumpectomy with radiation. And results really shocked our surgical world. And as a surgeon, I think, I don't know, back in the day, I'm sure the surgeons did not want to accept this. I'm sure it took them a while to understand why less surgery is the same survival as more surgery. Survival was the same whether you had this extreme surgery or having lumpectomies. And so it's not the bigger surgery that saves lives. It's understanding the biology of the disease and treating it with systemic therapy is very important. And like also reconstruction was once discouraged. In 1998, there is Women's Health Right Act that actually mandates insurance companies to pay for mastectomy on the other side of the cancer if women want to have a double mastectomy, or if they want to have reconstruction, or if they want to have symmetry procedure with reduction and reconstruction and oncoplastic reduction and so on and so forth. The options are so many now. There's implant-based reconstruction. There's autologous reconstruction where women can use their own body tissue. The other option is no reconstruction at all and go flat. And that's whatever is, good for the patient, that is what we do. And whatever is called shared decision making. And care increasingly centers on both the cancer control and also how women feel in their bodies. It's important for us to talk to our patients, and it's important for your surgeons to talk to you to find out what is the best thing for you. So for many patients, a breast conserving therapy, which is lumpectomy, sentinel node, or tailored reconstruction is okay. The most important things, the genomic assays like the mammoprint, the oncotype, those are important. That's what it tells you, the biology of the disease. It will tell you what systemic therapy is safe. So we can de-escalate the surgery, do lesser surgery, give you the same survival. The goal is effective treatment with least harm, guided by the patient's preferences. So are we done yet? No, we're still asking the questions. Some patients still can benefit from a mastectomy or more extensive surgery. So this is not one size fits all. It's a very personalized treatment. When we enroll patients in trials, we are asking questions. Can we omit axillary surgery? Can we shrink tumors with the chemotherapy before surgery? Also, the other questions, equity. And this is why I'm here on this podcast is I want to give this information not only local to my Columbus, Ohio patients, but also across the country, across the world. And I can do that from my living room. And that is the advantage of the social media and the privilege of being on this podcast. And in those countries where this access to advances is not available, we need to fight for that. The evolution of this surgery de-escalation did not happen in isolation. Women questioned surgeons, women questioned doctors, and that's okay. But know that when doctors are talking to you about the randomized control studies, there were thousands of women that sacrificed themselves to give you better options for the future. And again, it happened because patients questioned, advocates demanded funding, women entered medicine, survivors like myself, we are sharing our stories. The questions we're still asking, quality of life needs to become part of the conversation. I bring this up at every tumor board conference that we have. When physicians are talking about survival, I ask about quality of life. Body image, that's a big part of the conversation. Body image is something we all suffer even before the cancer diagnosis. 85% of us suffer with body image issues. And now you put the breast cancer into the equation and it becomes even more worse. Mental health has to become part of the conversation. Whenever a woman has the diagnosis of breast cancer, goes through the treatment, taking the anti-estrogen medication, it impacts the mental health of a woman. And as a woman surgeon practicing today and stand on the women who refuse to accept disfigurement as the only option, I am so deeply grateful for these women who came before me. And as a survivor, I'm deeply grateful for the science that allows women to today to choose and ask questions and to become their own advocate. So when we combine evidence with compassion, that's when healing truly happens. And thank you so much for joining me today. If this episode meant something to you, share it with someone who needs to hear how far we've come. Because progress matters and women's history in medicine deserves to be told. These are all the abbreviations. If I use any abbreviations, these are all listed here. The trials and the society name abbreviations are listed here. And remember, this is for educational purposes only, for not for medical advice. So if you need medical advice, please talk to your doctor. And thank you so much for tuning in and for watching and for listening. This will be available both on the YouTube as well as the podcast. Hope you all take care of yourselves, advocate for yourselves, empower yourselves, and educate others so we all rise together. Thank you. Bye-bye. Thank you, everyone, for tuning into the Breast Cancer Podcast. Remember, you're not alone in this fight. I encourage you to be an active part of this podcast. Please share your stories, questions, and suggestions for future topics at my website called drdipahalaharvi.com. And please share this podcast with others, especially if you found it useful. And please also give it a 5-star rating, if you will. Stay connected as we navigate the complexities of breast cancer. Until next time, take care and keep shining brightly. Disclaimer: this podcast is not intended for complete medical advice, so please talk to your medical professionals.